Part 2 of Going Under Anesthesia Answered with Dr. Brian Schmutzler, and our guest is Dr. Adam Cien, orthopedic surgeon here in the Michiana area, and you could say business owner as well. You own your own practice.
Small business owner.
Yeah. And we're going to talk a little bit about that here during Part 2. In Part 1, we kind of touched on working together, what orthopedic surgery is, and how you guys get along in the surgery room and in the OR. But this time around, we're going to talk a little bit about the business of medicine. And, you know, we talked about different pathways, and is there different pathways for orthopedic surgeons and for medicine in general moving forward? What does that look like? We're also going to do a fun game at the end, so you want to stick around between these two. Maybe I'll get involved too. A little Q&A and quizzing, Jeopardy, if you will, coming up later. But Adam, welcome again.
Thanks for having me.
And let's just dive right into it. Brian and I have talked about this extensively, and we touched on maybe the future of, you know, orthopedic surgery. But where do you see the future, 10, 15, 20 years out, the future of medicine? Where is it right now? Where is it headed in your eyes?
That's a great question. I think that, you know, we're in kind of an inflection point in medicine right now. We're seeing, you know, stories countlessly on, you know, social media about, you know, extensive medical bills, you know, what's insurance covering, what's not. We're seeing record profits for all these insurance companies. And, you know, and our healthcare, you know, when we look at it and you look at other Western countries, you know, we're not number one in a lot of different categories. And so there's a lot of room for improvement, yet we're spending a lot of our GDP in medicine. So I think we're at an inflection point where people are starting to wake up to, you know, the healthcare that's being delivered and the cost of that, and it's definitely going to change in the future.
Can I ask you guys a question related to that? Part of the American dream back in the day, like at least from my parents who moved to this country from a Middle Eastern country, was the health care that you received in the United States. Is that still part of the American dream? Like if you were living elsewhere, would you still, and knowing what you knew, would you still take the American healthcare system over any other healthcare system?
Yeah, I think we do the best job overall. We have the newest things. And to say that people don't get health care in the United States is disingenuous. Everybody gets health care. Now, it might be expensive and you might not have health insurance, but if you walk into any ER in the country, they're going to treat you, and they're going to treat you well, right? So that was 1986, a law called EMTALA. You have to be treated, right? So yeah, still the United States has the best healthcare system in the country. Do we have the most efficient healthcare system in the country? Do we have the best spend? No. And I mean, I guess in my opinion, that's because of all the intermediaries, including the federal government. You got the federal government that has their hands in it, basically practicing medicine without a license, right? A Medicare can deny or approve something just based on what they want to do. And that doesn't have to be a physician deciding that. That's, you know, somebody at a desk. Same thing with the insurance companies. The insurance companies are incentivized to not pay for your health care because they have shareholders, and the more money that they take in from premiums and don't pay out in care means more money for them and more money for their shareholders. So we have a screwed up system with insurance, period, and then with the federal government being involved as much as it is. I get it if you want a healthcare net, right? So you've got to, somebody's got to pay for, you know, somebody who's homeless or, you know, who doesn't have any money and can't afford any sort of healthcare on their own. But, you know, having everybody over the age of 65, including the multi-billionaires out there, they get Medicare just like everybody else. So it's, I don't know. I ran a little bit, but that's my...
No, I would, you know, the first question about, you know, our healthcare system definitely is probably still the best. I mean, I believe there was just a news article about Kate Middleton coming from England for her cancer to MD Anderson, you know, down in Texas, and, you know, all the...
What did it end up being? Was it colon cancer?
I don't think there's been an official diagnosis.
Because we had a TikTok, or do we do that?
I don't know if we did that one.
Zane did. Dr. Hassan did, about whether it was colon cancer or
I don't think they officially said anything yet.
Or GYN cancer. Anyway.
Yeah, but you know, all the Middle Eastern countries like UAE, Dubai, they're all flying to Mayo Clinic. I mean, there are special VIP floors there with restricted access and fancy rooms, and I mean. So everyone's coming to the United States for healthcare still. Like Brian said, we still have the best technology, we have the best doctors, we provide the best care, and like Brian said, it's probably not the most efficient, use of our money. So that's where, medicine's probably going to change in the next 10, 15 years. So you're probably going to see a split, and we'll probably go to, probably a kind of a two-tiered system where there's probably going to be a Medicare for all type of safety net where, it's going to provide some catastrophic care, and you have car insurance, but your car insurance doesn't pay for your oil change.
Right.
It doesn't pay for your windshield wiper, and your insurance does for healthcare. And that's probably got to be a change in perspective and in understanding for the average citizen. Is that we need to probably focus more on preventative care, and where you go to the doctor, you go to your PCP, and you pay for the Tylenol, you pay for that $100 visit out of pocket. You're not expecting your insurance company to pay for your $27 Tylenol or prescription medication.
Would 15-year-old you guys choose it again in another 15 years?
So if I was 15 now, would I go into medicine again? Probably. I like what I do. And I think, and we've talked about this a little bit, if you can niche yourself into a system where you're doing what you want to do and have other ways of sort of supplementing what you do besides just going into an operating room every day, I think that's what we both do, right? It's not like we just go in and hey, you showed up today, here's your paycheck, and we do other things. So yeah, I'd probably do it again.
Yeah, 100%. I love what I do. Every day I wake up and I go to the operating room or the clinic, and it's something I'm passionate about, and I would not change anything that I'm doing. We talked about, or you kind of alluded to in the beginning, there are multiple ways, of practicing medicine. So I'm a small business owner. I work for South Bend Orthopedics. I'm one of the owners. So we own, our group practice. So I'm not beholden to anyone except my partners. I'm my own boss. If I want to take the next 3 months off, no one's going to bat an eye. I still have to pay my overhead and my employees and my salary, but I'm not beholden to some hospital administrator. So there's been a big pendulum in medicine where I think the largest employer of physicians right now is an insurance company.
Yep.
I think, one of the, like HCA or Optum, one of them, I mean, they own and employ surgeons, like one of their entities, they don't directly, but it's like, so the pendulum has definitely swung to, employed models.
Employment, yeah.
Because
what's the benefit if I'm a young person coming out of medical school? What's the benefit of working for Optum or United or whatever rather than going to work for a hospital system or a clinic?
Well, they offer you a huge payday to start with, and then they start cutting it back and basically making benchmarks that you can't meet, so that they start taking money away year after year. But it's I mean, most of us when we come out of college are used to just getting a job, right? Like that's all you hear, right? You go work for Goldman Sachs, you get a W-2 job, right? You're employed. You go work for whomever, IBM,
right?
Google, you're a W-2 employee. That's what people know. It's a little different being an owner or even an independent contractor at 1099. I think it scares people. Like, what do you mean I don't get benefits? I don't get health insurance. Right. I don't get, CME credits. I don't get my medical malpractice paid for. So I think it's scary to people because they don't understand it. But I mean, the disadvantages of employment, I think, are much more than the advantages of employment, in my opinion.
Yeah, I think there's a lot of short-term advantages for being employed. In medical school and medical education, even college education, is out of control costs in this country. I mean, it's several $100,000 to get a college education if you don't go to your state school, and then you go to medical school, and that's expensive. And you're talking about several $100,000 in debt, and so it's easier to go to a hospital, get a big payday to begin with, get some loans forgiven, and then you settle in, you have family, you have a house, you've kind of bought into the area. Now it's like, okay, they're gonna start cutting your big paycheck to a smaller one. But now, man, I have 2 kids in school. We have a big friend group. We're kind of beholden. We're kind of stuck in the area, kind of like almost like golden handcuffs.
Yeah, but the FTC might have fixed that for us. So.
Yeah. I think he's talking about the non-competes.
Yeah.
So,
Yeah, right.
a lot of these contracts have non-competes where, hey, you know what? You also can't leave because you have to move.
Yeah.
And, that kind of monopolizes the area. It's really unfair. I mean, there's advantages and disadvantages to it. As a small business owner, great. I don't want my partners to leave and be like, you know what? I'm going to cherry pick these 3 great partners. I'm going to go across the street and compete. But at the same time, that should make us better. We should. Competition breeds, better success, better care for patients.
Yeah.
Better pricing, everything. And so, these big hospital systems are gobbling up practices. And what you'll hear in the media is that, consolidation helps patients. It gives better access to care. It doesn't. It basically gobbles up and drives costs up because now there's no competition. Imagine if McDonald's went and bought every single fast food chain, Wendy's, Burger King. All of a sudden, that $5 Big Mac meal is going to be $20 because why not? There's no competition.
Well, and the product's not going to be as good because why should they be as good, right?
If you don't have anybody to compete with, right? Exactly. I mean, that's why in a lot of places, I mean, even in Indiana, when one health system tries to buy another, I'm not a big government oversight guy, but in some cases it helps, right? Because if let's say IU Health, they were trying for a while to expand over the entire state of Indiana, if they took everything over, it'd be a problem, big problem.
Yeah, and that's what's allows us as small business owners as well is to pivot on a dime. When COVID happened, we were able to kind of pivot to a smaller local hospital and start doing cases and providing care. We're able to make decisions on the fly. We're not a big mega corporation who has shareholders or some corporate oversight 5 states away to make decisions.
Is the way to go here? I mean, we were talking a little bit about the shift in medicine over the next 15 to 20 years. And you said, more than ever, it's become, government involved and people who are not involved in medicine making medical decisions.
Yeah, I mean, this is hyperbole, but it's basically people without a license practicing medicine. I mean, that's essentially what it is.
Yeah, it's bureaucrats making decisions and making laws and enforce and different policies that, affect everyone.
Is it prudent to say that if you're going to be a physician or a surgeon or a doctor or anesthesiologist, maybe the best path to go forward is practice what you want to practice, but also own a surgery center, own a business? Is that, we were talking about in the 80s and 90s, right? This aura around surgeons of, any physician really was, hey, if I want to make a lot of money, I'm going to go become a physician or a surgeon or whatever, right? Like that aura still exists today. And I think there's a fair misconception out there of patients who are like, well, the surgery is costing me $25,000 and the doctor is pocketing most of that money. Like, I mean, there is some misconception out there that this exists. What do you have to say to that? And answering that kind of in a 2-part answer, should physicians maybe choose these routes to go as well? And that money question.
I wish I made $25,000 every time I did a surgery. That'd be fantastic. But that's just unrealistic. And so, how our insurance companies are set up, I think Brian alluded to this earlier. It's meant to be confusing. You have what the facility charges, what the surgeon charges, what the co-insurance is, your copay, your deductible, what's allowable. There's, when you look at your bill, there's 80 different lines, and then there's
it's 30 pages for a simple toe amputation.
Yeah.
I mean,
it's meant to be confusing, and it's meant to, having all these companies trying to take all these insurance companies, these third parties trying to nickel and dime and take, some money away. And so, it's really confusing. And so people post on social media, wow, look at my $150,000 bill for going to the ER and different things. And, is that their actual bill? Well, if you have no insurance, the hospital's going to probably charge you $150,000 cash. But, when you go and call and, try to put your foot down and try to say, hey, I'm not paying this. Like, what is the actual price? It can be negotiated. But most people don't know that they can call and complain and figure out.
You can negotiate a healthcare bill.
Oh, yeah.
Oh, 100%.
Yeah. So we talked a little bit about this before. So there's a difference between a charge and what you collect, right? So the insurance companies make us play this little game where we have to set up, we're going to charge X amount, just make it up, $100, right? Our charge master is $100, but they're not going to pay that because you have a negotiated rate with them. You have a contract, and the insurance company might say, we're paying you $25. The reason you have that charge master, though, is because the insurance companies look at that and they think they get a better deal if your charge master is $100 and they're paying $30. So what you're getting charged is a made-up number, right? What you get on that bill, here's your charges, completely made up. Nobody ever pays $125,000 for an ER visit. If they don't start paying on it, the hospital will call them, even if they don't call, and say, hey, you don't have any insurance. Your bill from the ER was $125,000. For a self-pay discount, we'll give it to you for $10,000. Then you can pay it over the next 5 years. So, it's just... It's a game. It's all a game in order to make these insurance companies actually pay what they should pay. And it's just goofy. The whole thing's goofy. But if you don't understand that as a patient, you see that bill and you freak out. So,
and this is something that is not taught. So, it's surprising. I think most people would think that, in medicine and medical school or even in residency, you have a business course on, what you get paid. We never discuss, there's any course on reimbursement, how much doctors get paid, how does insurance work.
That's surprising. Honestly, that's surprising. Yeah. There's no finance course
it
associated with
100%.
Medicine.
It should be like day one. Let's talk about insurance companies and how you get paid as a doctor. Because we all go into medicine, if you wrote on your personal statement, I'm going to medicine because I want to make money and be...
you wouldn't be.
That application is going straight to the, garbage.
Right.
They want to see, I want to, make $0 and I want to help the homeless in Venezuela and travel the world and build orphanages and help people.
But our favorite hospital system says no money, no mission, right?
Correct.
So...
Correct.
Just saying.
And it's, you got to make a living. This is just a job, just like anything else. Just like you have a job here, the CEO of Amazon has a job. Everyone has a job to make money. And it's a taboo subject to talk about money in medicine because we're trained and instilled in college applications and medical school applications that this is an altruistic field. We're sacrificing our lives.
It's mission 100%. Driven. And yeah.
I would say the other thing that they don't teach us is that the insurance companies can just decide they don't want to pay us yet. I'm just going to hold your claims for how long did one large insurance company hold your guys' claims?
I don't even know. A year.
Yeah, almost a year. Yeah, just didn't pay any. Just didn't feel like it. Just not going to pay it. Yeah. And we have no recourse. I can't call up Nuco Insurance Agency and say, hey, you haven't paid me. You have to pay me. There's no laws that make them pay us. So they pay us however they want.
So if you're part of a hospital system, though, does the hospital still have to pay you?
Yeah, oh yeah.
But if you're an independent owner...
So yeah, this is, the cyber attack on one of the insurance companies.
Change
Healthcare. All of a sudden, they are just not paying bills. And so when you're a large mega corporation hospital system and you have $1 billion or whatever coming through your, coffers the other way, they're going to survive. But, small business owners who run small practices, we don't have just cash sitting in the bank to, weather the storm of the healthcare company going, you know what, we're not going to pay the ransom. We're just not going to pay bills for the next 6 months.
Can't afford to do that.
Our employees still want to get paid.
Yeah.
Right.
The lights need to get paid. The vendors need to get paid.
Right. Yeah.
But we're having no money come in.
I don't have that option. I can't just call the electric company and be like, hey, listen, I got hacked. I'm not paying you. They're gonna shut the lights off, right?
Yeah.
Yeah. It's really interesting to hear your perspective versus somebody on the internet who's just, these guys just rake in all the cash and you know, they don't have to pay employees or overhead or worry about any of that stuff.
So I mean, that's an advantage of being an employed physician,
Right.
You know, so if I work
Right.
for mega corporation or mega hospital system,
You're
know,
going to get paid.
I don't. Who cares that, you know, Change got hacked and the hospital's not getting a paycheck? I'm still going to get paid.
Yeah.
So you know, there's no headache of running a small business and worrying about your employees and worrying about your costs.
So medicine in 15 to 20 years is what? Fill in the blank.
Difference.
I agree with what Adam said before. I think there's probably going to be a 2-tier system. I don't know that we'll go fully to Medicare for all, but there's going to be, and we talked about this a little bit too, there's going to be direct, basically DPC, direct physician care, where, you know, you're going to say, hey, this is your, just like, you know, when you join a gym or whatever, this
Paying
is your
cash
monthly,
a month.
pay your cash, this is your monthly fee. And then there's going to be everybody else who has insurance. And this insurance care is likely going to get worse and the direct physician care is going to get better. That's my guess.
Yeah, I mean, like, you know, I think in Canada, you know, there's a long wait list for, you know, knee and hip replacements or getting an MRI. You know, it's an elective surgery, and if you have, you know, just the government healthcare, you might wait 8 months to get a total knee, and others will just come across the border and get a knee, you know, next week, you know, in the United States. So, you know, it's going to be some probably kind of combination national healthcare system versus, you know, insurance based versus cash pay.
The reason, though, I don't think insurance will go anywhere is because they have so much lobby control over the federal government that, and there's so much money that goes through their pockets. There's no way insurance is going away. I mean, it could end up like Obamacare, where all these insurance companies just basically are the vehicle for the all government insurance. It could go that direction, I guess. But
yeah, you know, but like Medicare Advantage plans, you know,
those are brokered by the insurance company,
which are you know, a lot of them are dropping now because they're not as profitable, and you know, it's a big mess. And so there's too many, you know, hands in the cookie jar. There's too much lobbying power. You know, the American Hospital Association has, you know, they're one of the biggest lobbyists, and one of the biggest changes in Obamacare was physicians can't own hospitals.
Yeah.
You know, that's like saying, you know, you can't own
a camera
or own a camera.
Yeah.
Or you can't own the studio.
On a camera store,
Yeah,
right?
Or
right, yeah.
the lawyer can't own the law firm.
Which is a ridiculous
Right.
thing to say.
And you know and the hospitals have such a high lobbying power that, you know, the small guy, the physician, can't really lobby against that. And so, you know, in 2010 or whatever, when Obamacare got passed, you can't own a hospital anymore.
It's really interesting.
Yeah, I don't remember where I was going to go with that. Yeah. Anyway, move on. You're fine.
Well, no, listen. It's been a spirited discussion, and Dr. Cien, we should have you back for sure. I enjoy you being part of the podcast. I don't know about the guy that the podcast is named after, but you know.
Oh, here's what I was going to ask. So with the baby boomers, right? Don't you think in 15 to 20 years, most of the baby boomers will be no longer with us?
Yeah.
So I wonder what that does, because then you've got a precipitous drop in the amount of people needing care, and especially like hips, knees, and a lot of the end-of-life care. I wonder if that does something to like restart
reset the system, where like rebalance how much, you know, because we spend so much at end-of-life care.
Yeah.
You know, it's, you know, no one wants to talk about it, and they always call them, like, you know, the death panels. You know, when they were talking about, like, you know, should we talk about end-of-life care when 90-year-old grandma is on a ventilator in the ICU at, you know, $20,000 a day? You know, that's you know, it's a really hard conversation to have with family and friends, but at the same time, we're spending a lot of healthcare dollars. I mean, I think it's like 80%. I'm probably making this stat up. Someone's probably going to correct me, but it's like 80% of all healthcare dollars are spent in the last like 2 years of your life.
Yeah. So, and we do a lot of things in the ICU that we probably shouldn't, just to keep people who alive who are essentially already dead, right? Because we have great tools now, right? We can make your lungs work, we can make your heart work, we can make your kidneys work. We can basically keep every major system in your body working, even if you're not alive. So it's interesting to spend some time in like a high level ICU, because it's you know, it's a lot of care for people who probably would be happier and better off if we just said, hey, you've lived a great life, and let them pass peacefully. So.
We want to end on this note, by the way. We want to do a little trivia Q&A. So how this is going to work is I want you guys to quiz each other about each other's professions and see if you know the answer. I don't know the answer. I don't know the question.
So like quick questions?
Yeah, just quick kind of like, one hitters, right? So let's see if you can answer some questions about the other's profession.
All right, who's starting?
You can start.
All right.
Your podcast.
Easy questions only.
How long do you have to wait after eating food before you can have surgery?
Oh, I know.
What type of meal?
Doesn't matter.
Clear liquids, 4 hours. Full.
I know.
Full meal, 8 hours.
I know.
Close. Clear liquid's 2 hours. Full meal 6 to 8 hours, and actually breast milk is 4 hours. That's the one odd exception.
What?
You're
what?
right. Why? I don't know. Easier to digest. I have no idea.
No, but like what?
I don't know.
Like who's? I don't want to ask that question. Who's drinking breast milk before surgery?
Babies have surgery.
Yeah.
No,
babies
no,
have
no. I
surgeries.
mean like adult
No,
wise.
babies have surgery.
Yeah, babies.
That's why they say breast milk. So
Yeah.
you can feed your baby up to 4 hours before surgery.
Sounds good.
Weight for weight, what is the strongest bone in the body?
Ooh, weight for weight. What's the strongest bone in the body?
What does that mean? Weight for weight, like just pound wise,
Yeah,
like
like
you
a,
know.
a smaller bone, but might a stronger bone.
Denser.
A smaller bone, but it might be stronger. Hang
It
on.
sounds
let me
like a
think
trick
here.
question, but not a trick question. So
I want to guess.
I mean, it's either the femur or the humerus. Femur. I'm going femur.
Pound for pound, like I don't know. How about the hip, the pelvis?
it's the femur. So you guys are both like correct.
Bam.
Yeah, you're both correct.
Bam.
All
All
right.
right.
The femur is like, I think, they'll say it's like 4 times as strong as concrete or steel or something like that. It's
It's a dense bone.
And
It's
it's
a
the
dense
biggest
bone.
bone in the body,
That's
It's
correct.
the longest.
longest bone in the body.
All right. So you hear about all these medications.
Is it dad
That we
jokes?
make-
Are we?
that we- no.
Where are we going?
So you hear, no. Listen. So no, this is my next question. I'm up, right?
Yeah, you're
okay.
up.
So you hear about all these medications, all right, that we make people stop taking because it can make them throw up during surgery. Number one, it's a 2-part question. Name one of them, and number 2, what's the class of drug?
Ozempic.
Okay, correct. Class of drug.
It's like a GLP-1 inhibitor or something like that.
Close. GLP-1 agonist.
Oh,
Close.
We'll give you a half point for that.
three
one.
quarters. 3/4 of a point.
So you got 1.75 out of 2. Well,
Okay.
no.
Yeah.
Yeah, 1.75.
Well,
no.
he got the first one wrong.
Yeah,
I
one
think
out-
points-
well,
points
let's give
at-
him 1 out of 2.
Fine, 1 out of 2.
Are you 2 out of 2? You're 1 out of 1.
1 out of 1.
I want to make these nice and easy for Ryan, anesthesiologist. So, true or false? Your fingers can support your entire body weight.
True.
That's correct.
2 for 2.
2 for 2.
All right.
They're too easy. I'm going to have to make them harder.
Last one, unless there's a tie.
Okay. All right. So this is another big one. You should know this because you're on like the board and all this stuff. So,
I like how there's always like these,
medication question. So there's a drug out there that's super expensive that a lot of places didn't want us to use to reverse paralysis, but the ASA came out with these guidelines that say you should really use it on everybody. Can you name that drug?
It's in there someplace.
Yeah.
It's in crash carts now.
It is. It is.
Ooh,
Nothing.
I can't.
Sugamidex. Sugamidex.
Yeah,
It was
not-
there.
I was not
it was
going to
there.
get that.
It was there. All right.
The Bee Gees had a song, 1 out of 3 ain't bad. Was it? No, it's Meatloaf.
Meatloaf.
2 out of 3 ain't bad.
Meatloaf. Two out of 3 ain't bad.
One more for him, or are we done?
Yeah, no. I want one more question.
What's the most commonly broken bone?
Toe. Big toe.
Man, look at you.
Yeah.
Look at you.
Well, I used to study the encyclopedia.
I
for-
did. I did.
Yeah. Think about it. Everyone stubs their toe
Yeah.
walking around,
Yeah.
and that's how you basically break
Yeah.
your toe.
Man, Nice job.
He's
Nice
crushing it.
job, Brian.
I know.
True or false? People should follow you guys on social media.
True.
Double true.
Double true. Nice.
Double true.
Double true.
They're both on Facebook, both on Instagram. They make great content together.
And separately.
And separately. And if you're not checking out Dr. Cien's pages, you definitely should. Knowledgeable, funny, dry sense of humor.
Better looking.
Better looking. Definitely. Scrubs are probably more comfortable. I don't know.
Dang.
I'm just kidding.
Come on my podcast and insult me. All the 80-year-old women love me, all right? Just saying.
It's not a true fact.
Dr. Adam Cien, orthopedic surgeon, thanks so much for being on the podcast.
Hey, thanks for having me.
Hey, you're welcome back anytime. All right, Dr. Brian Schmutzler, we'll see you in the next one.
See you later.